I'm going to start with a few slides and then have some comments. But I think the easiest thing would be to start. I thought I'd just run through the milestones in hepatitis C discovery. It all began with non-A, non-B, a very strange name, but that's what we called it. And that was discovered in 1975. So that's 25 plus 23, about something 8 years, 48 years. That's a long time ago. But the discovery led through sequential studies to show that this non-A, non-B agent was actually bad. It was thought to be just a simple transaminitis at first, but it was proof that it could lead to cirrhosis, end-stage liver disease, and then to hepatocellular carcinoma. Big breakthrough came in 1987 when Michael Houghton and the Chiron Corporation cloned the non-A, non-B agent, were able to develop the first test antibody to that agent. That was really the big mover here. And with that test, we were able to virtually eliminate post-transfusion hepatitis in countries that could do the testing. Then came in 2011 these direct-acting antivirals that, as you know, are now really can cure virtually 100%, if not on the first shot, on second trial, second treatment. So it is what's allowed this group to move forward because we have a way to cure people. So that was that test and treat strategy to eliminate hepatitis C that I'll show you I don't know about the Egyptian effort to actually prove that this could be done. I'll show you one slide of that. But what we still need is a vaccine. We do not have a vaccine. There were a few in the pipeline, but how do you test a vaccine now that we have no animal model? We have can't use the chimpanzees anymore, who was so instrumental in the whole non-A, non-B story. So we had a meeting just last week to talk about CHIM, not chimp, but CHIM, Controlled Human Infection Model. We're going to have to go directly to humans in small scale to test these new vaccines as they come along. It's a complicated slide of CHIM, but basically you start out with an inoculum that's proven to be infectious. Ideally, you get a sample from a person who is acutely infected, because at that point the titers of the virus are the highest, and they're not yet immunocomplex with antibody. This would be an ideal infectious inoculum. Not easy to find somebody, catch somebody in the acute phase because people are asymptomatic at that time. But I think we will. Then it goes through a complex process that we don't need to go through, but the point being in the right-hand panel is that we can now test infectivity, not test the efficacy of the vaccine, but we can test the infectivity of this inoculum in a chimeric mouse model, human liver inside of a mouse. And we can also test it in culture. So we can test its infectivity titer, and later on we want to know whether we have neutralizing antibody with culture. And then we need volunteers. Somebody's got to volunteer, maybe somebody in this group, to receive this infectious inoculum, because we know we can cure you once you get it. So that's the only reason you can do this, Jim, have these curative therapies. Before we even do that, we have proven that this inoculum is susceptible to the treatments, and that you can do that in culture, and that it doesn't have any resistance mutation. And you start out with just a few people, and then you expand it, it works. And then you can do a real efficacy trial in a small number of people get the vaccine, some do not get the vaccine. You're not just looking for infectivity, because the vaccine may not be sterilizing, may not prevent infection completely, but we think it will prevent chronic infection. Prevent chronic infection, that's all you need to do. So that's where we're going if somebody comes up with a good vaccine. We know that HCV can be eliminated because of these three things. Very importantly, there is no non-human reservoir, so we're not going to get bitten by a mosquito. We're not going to get it from other sources. We're going to get it human to human. We know we have the sensitive test now, which is now becoming point-of-care tests. We can even do point-of-care PCR. So that's going to make it much easier to project. And then we have the cure. So that we have everything we need to actually eradicate it, except building the infrastructure to do this. That's why you're here today. And Egypt has already, you've seen these slides before, but Egypt has already done this. They screened, tested 60 million plus people. They found 4% to be positive for RNA. Treated over 2 million people, and they cured virtually everyone. I'm sure those few that missed treatment were retreated. I don't have the numbers. It only costs $50 to $150 because Egypt developed their own drugs and they developed their own tests. So the actual tests and drugs became very inexpensive, such that the government could afford to test 60 million people. Last I heard, there were only about another 350,000 people needed to be tested in Egypt to really say it has been eliminated. And it's just a remarkable accomplishment. This is what we want to do everywhere, but I don't know how many Egypts we have in the world. We're going to try. So I just wanted to end with this slide. I was trying to think of what is the enthusiasm. If you had a treatment for any disease, a treatment that would cure somebody 8 to 12 weeks, that had no side effects, that could be taken, how enthusiastic would the world be to implement such a treatment? Well, if it was cancer, we'd be on it like that. Any cancer. We knew we could get rid of that cancer in 8 to 12 weeks and forget about it. If it was HIV, we'd do the same. Everybody would be on board. We'd get rid of HIV with a test and with Alzheimer's, same thing. Major enthusiasm. TB, a little bit less. It doesn't strike our chord doing these other diseases do. If it's hepatitis C, it's down here. Somehow this disease, because the bad outcomes occur so late after the onset that the layperson doesn't put those two together. And that's the message we have to go. So basically, how come we don't get no? And I'll get back to that in a minute. So that's kind of just the background for the meeting. But I'm impressed that you people would travel so far and have such enthusiasm and join this group of friends, get in on this project, which is doable but extremely difficult. It makes me wonder why everyone doesn't have that same enthusiasm. How often can you participate in a project, eradicate a disease, chronic, fatal disease, and you can eliminate it in 12 weeks, maybe 8 weeks, maybe. You don't get this. It's never happened before. This is our goal. So I'm neither a psychiatrist or a neurologist. I don't know what drives the human psyche, not even my own, particularly not my own. But I think humans are wired first for survival, and second for self-interest. There's only a small cadre of humans that can see beyond themselves, the other person. Really be involved in something good for humanity, good for global health, and that is doable. So I see this UN group of friends as part of that small cadre, have this vision, willing to work hard to make this happen. Human health and human survival. Thank you so much for your efforts. Forward to today's meeting. Thank you. Thank you for those of you who stayed. It's a great morning, John. Thank you for organizing that. So, you know, hepatitis B and C, though they share a commonality in what they do to the liver, the eradication strategies right now are quite different. Because one has a vaccine that's very effective and treatments which are not curative. The other has treatments that are curative but no vaccine. So the approaches are going to be somewhat different. But we can start it all began, the hepatitis B story all began with a chance finding of a unique precipitating line in UNGA that was a reaction between a multiply transfused hemophiliac patient and an Australian Aborigine. So it was called the Australia antigen initially. Later, when many different studies from many investigators showed that this antigen was really the surface protein of the real hepatitis B virus, the so-called Dane particle. This is the hepatitis B variant. And you see that nice surrounding capsule on the infectious particle. And that's consisting of all hepatitis B surface antigen now, but was the original Australian antigen. So here's my report card based on the World Health Progress Report in 2019, so Meg will update us on this, or somebody will update us on this. But the idea, the exact numbers are not as important as the concepts. But that time there were 292 million people living with HBV globally. That's a lot of people. And 800,000 die each year from liver failure or hepatocellular carcinoma. We go back to my slide. I'm seeing the introductory slide, not my slide. Okay, great. So again, maybe the number now is 1 million die annually, but anyway, it's a lot of people. An important point for this meeting is that only 10 to 30% of those living with HBV actually know they have it. That's very similar to HCV. And only 15 to 30% of those who know they have it actually are getting treated. These numbers are mostly talking about adults, but it applies to children as well. But this birth dose coverage is only, as in 2019, was only 42% overall, and only 10% in sub-Saharan Africa. So the goal of this group is to really concentrate on that birth dose. It's the most important thing that can be done. So again, for B, primary prevention is the story. Mother to infant transmission is the most common route of HBV infection, and it carries the greatest risk for hepatocellular carcinoma. Happens way later. These kids are not very sick, and they go for decades and decades, and they have hepatocellular carcinoma. Given the vaccine, the simple vaccine, but it's so effective. Given that vaccine within the first 12, ideally 12 hours, but up to
24 hours at birth is a cornerstone of HPV prevention. And that's hard to do. You got to get a vaccine shot into a baby almost right as soon as they're born. That is the biggest impediment probably to this program. But you can supplement that initial vaccine with another dose at 6 months or when they go to school. But the transmission occurs at birth. That's the big transmission. So if you don't get that vaccine early, you have trouble. Another thing, if we could test, some places are able to test mothers in the 3rd trimester to test for hepatitis B surface antigen pre-delivery. That allows you to treat the mother with tenofovir or any other hepatitis B inhibiting agent. And then you also know that this child is going to be at risk, and if the child's at severe risk, you can add hepatitis B immune globulin to the birth dose of vaccine. But there are impediments, I've said, to this program. It's very difficult to implement this in low resource settings, to organize to get the birth dose in time. There is some problems with cold chain. If the vaccine you're using requires cold storage, that's a real problem in hot areas, warm areas. But you need skilled healthcare workers. You need people who know we've got to test the mothers, we've got to test the babies, we've got to just give the dose to the babies. That's the main thing. And maybe another big impediment is home births or field births. So not every baby who's born is born in the hospital. And in Africa, that's a big problem. The babies seem to get out okay, but they don't get that birth dose. So how can you set it up that babies born at home or wherever, but not in the hospital, can get a rapid dose? That's a real challenge. The efficacy of vaccine, whereas Egypt is the poster child for hepatitis C eradication, Taiwan is probably the poster child for hepatitis B control. Prior to 1984, in Taiwan, almost 30% of children had anti-core antibody for hepatitis B, and 10% had hepatitis B surface antigen. So in 1984, they started testing mothers and vaccinating the babies. But then after that, that was very successful. But then they went into universal birth dosing and implemented that very well. And you can see by 1994, the surface antigen had fallen to about 2%. Anti-core antibody had fallen to 5%. And by 1999, even further falls. So the whole country of Taiwan has been able to implement this birth dose vaccination. And it's been very successful, not only in what I just showed you, but also in preventing hepatocellular carcinoma. These are figures only 8 years into this program. And if you look at the green bar, the last bar, no matter what age, there has been a 20 to 40% decrease in hepatocellular carcinoma incidence. So the birth dose is affecting the long-term outcomes, and these numbers will continue to go down. In terms of adults now, I didn't know this was going to be a pediatric focus session, but in terms of treating adults, we can't cure adults the way we can for hepatitis C, because there's this cccDNA inside the nucleus is a replicative form of the virus. So even if you get rid of it in the serum with hepatitis B, the liver still can regenerate more agents. So everybody's working to get a way to control this cccDNA. but we don't have that now. So we're settling for this functional cure, which is that the treatments will lose hepatitis B surface antigen, that HBV DNA will not be detectable, that liver disease will become inactive, the ALT levels will normalize, fibrosis that's already there will regress over time, and the risk of hepatocellular carcinoma will remain, but it goes down quite dramatically if you can achieve a functional cure. But the cccDNA will still be present, so it's not a quote cure. But this is akin to the SVR, sustained virologic response in hepatitis C, except that it's not curative. But it really, if you can really lose surface antigen and achieve these functional levels, you can have a big inroad on liver disease and hepatitis B. This is a complicated slide, but just there are three main routes to achieving this functional cure. We can inhibit the viral replication, which we do now with nucleoside and nucleotide inhibitors, with liver hepatitis B entry inhibitors. We can lower the viral antigen load with small interfering RNA molecules. And we want to boost the immune response by a variety of ways, but antagonizing or increasing rather agonists to toll-like receptors and RIG1 to stimulate the innate immune system. So we don't need to go into those mechanisms, but mostly now we're stuck with these nucleotide inhibitors for replication and the viral entry inhibitors, Mercudex. But for B, there's a real limitation for this test and treat strategy. We have very few national policies for HBV testing of adults. It's very difficult to set up this infrastructure just as it is for hepatitis C, but we know it can be done. We had these presentations this morning that show you can get that infrastructure set up. HBV DNA testing is going to turn to be more expensive than the treatment. So we have to lower the cost of HBV DNA testing and hopefully make it point of care. With B treatments, they're not as simple as C treatments. They're simple, but they have more interactions with other drugs. We'll hear about more about this later. So you really need more highly trained people to administer hepatitis B treatment. Hepatitis C treatment can be given out by, well shown by healthcare workers at any level. The other thing with hepatitis B treatment is because it's not curative, it's like HIV, it's a lifelong treatment. So I won't get into this one, but the current strategies then are for B and C are different. If we want to go to elimination, for C, we're into test and treat. Test and treat can get us far. And even if it doesn't get us all the way to elimination, and I'm not sure it alone can do that, but it can get us very far. And we still, though, need a vaccine for C. There are some vaccines in the pipeline. Current vaccines, there's only one that has shown that it might prevent chronicity, and that was showing it in a chimp model. As I said, we're going to have this CHIM model, this human infectivity model, and we're waiting for somebody to say, hey, we got a good vaccine, let's try CHIM. B, on the other hand, depends on the vaccine to really eliminate. And the vaccine very dramatically has spread around the world. Again, I think we'll hear more about this. But I think it's already been a great accomplishment in how many people have gotten hepatitis B vaccinated. But there's still time to go. And treatment, test, and treating for B will be for those who are already infected, have bad liver disease. So maybe it's not perfect that we're gonna get to those endpoints by 2030, but I wanna emphasize that we don't want the perfect to be the enemy of the good. We can do a huge amount of good, whether or not we get to all the goals by 2030. Every person you prevent or you treat is an accomplishment. And we've seen this morning what's already being done for C, and B is on the same track. But if we can get that birth dose going to the peak, we can almost get to the perfect would be. So that's it for me, John.
Okay.